My pleasure to introduce Dr. Kate Davis, who will be speaking on developing and implementing a model for nurse-led coordination of transitional services, something that interests a huge amount of people. You might not know Dr. Kate Davis, but she is a registered nurse by profession and completed her PhD at University of South Australia in the Rosemary Bryant Research Centre with a focus on feasibility of implementing nurse-led care coordination services, particularly for people living with multimorbidities and provision of continuity of care across tertiary and primary health sectors. Dr. Davis is also an A&MF SA branch program manager for transition to professional practice.
Thank you. Thanks very much, and thank you for your patience, everybody. It's great to be here today. So my name is Kate Davis, and I finished my PhD early last year, and in that I was focusing on developing and implementing a model of nurse-led care coordination service. So today I'm going to be focusing on the issues and challenges of actually implementing that model. I'd like to acknowledge that, like our previous speaker, the traditional custodians of the lands on which we work and live, and recognise their continuing connection to land, water and community. And I pay my respects to elders past, present and emerging, and I acknowledge the stories, traditions and living cultures of Aboriginal and Torres Strait Islander peoples on this land, the Kaurna lands, and commit to building a brighter future. So in my presentation today, I'll just briefly show you the methodology, but then I'll really be focusing on the challenges, the system complexity, the issues and solutions, and what might be part of a way forward. So as you know, my question was really concerned with implementing, well, first of all, developing a model of nurse-led care coordination, and that was completed in phase 1. And I'm looking at phase 2 today, in which I was refining and implementing that model of nurse-led care coordination and continuing to validate it. And the workplace, my research was situated in an outpatient service and a multi-D clinic for people with multimorbidity at the Royal Adelaide Hospital. So I was basically with a multidisciplinary team for 2 years as we rolled out this nurse-led care coordination service with a participatory action research methodology. So it sounds like it might be pretty straightforward, but really it's pragmatic research. So I was prepared for a few challenges, but I can't really say I was prepared for so many challenges. So those of you who are embarking on your PhD or starting on pragmatic research, I hope some of these issues will sort of forewarn you today, and I'm happy for people to contact me to talk about them. So firstly, looking at the participants' challenges, and by the participants, I mean the nurses and doctors who were part of the multidisciplinary team supporting the implementation of a new service or model of care. These comments that I have up on the screen really reflect broader health system change that they were not really in control of, but were experiencing. So I guess the environment that the multidisciplinary team worked in was quite unstable and complex. And you can see some of these quotes. So we're a small unit, and getting people to recognise that we can make a big difference is difficult when so much of the work at an executive level is patch up, i.e. short-term solutions. There is no long-term vision. I think also underpinning that statement is that sense of siloing, that it was difficult to communicate with other teams within the hospital. And some of the patients even commented on this, saying that they felt that it would be difficult for change because people had their bailiwicks. And it was interesting that even patients had an insight into this difficulty in communication. And the second participant, SC2, said, I'm only new to the clinic this year, but there has been instability. There is a desire to grow the clinic, but I can't really say it's eventuated. It's unclear who the leader of the clinic is at present, And it's hard to communicate between other departments when, one, they don't communicate with you, and two, the best form of communication is actually paper-based. So the participant challenges were really multi-layered. And in the 2.5 years I worked with this team, I was the most stable staff member. The key challenge that we faced was workforce instability. So in those challenges and the workforce instability, what that looked like for me was 5 different nursing directors, 2 different heads of unit, secondment of senior nurses and relief nurses consistently moving through, rotating medical registrars. It was difficult to communicate with people beyond our unit, and it was also difficult to communicate with the primary healthcare sector, the GPs, the practice nurses, the IT systems, phone calls and factors were all inhibitors. So structures to support relationships and communication were not really established beyond Max. So we were stuck in the secondary healthcare system when what we were trying to do was build a system, build a service that went between the secondary system, the hospital, and the primary healthcare system. This was a comment from one of the nurses as well, that they had seen 5 different leaders fulfill their role. And whilst they've all been qualified and suited, there has been a lack of consistency. And from my point of view, from a researcher's point of view, that meant it was really difficult to get traction. Every time I went and saw an executive and explained what we were doing and how we would need to progress, they were all really positive and really wanted to get involved. But then, you know, a few months later, there'd be someone new. So although I've given a snapshot of challenges from staff on the floor, putting that in a broader context, you can see that there were 3 different executive nursing directors. This is not the local nursing directors. And there was unclear nursing governance. From the Callan operations point of view, we changed from a paper-based system to 2 different electronic medical record systems. There was a financial and structural review. There were 2 different missions and visions, 2 different state governments and multiple federal governments. And I'd just like to say, this was all before the pandemic. So just bear that into mind, that that complexity and instability all preceded what actually, you know, led us to this sort of critical point that we're now at post-pandemic, or sort of in the pandemic, really. And this is just a summary of the relationship between chronic health care policy internationally, nationally, and state-based. And if you just have a look down at the bottom where the hospitals fit in, I don't mean you to take everything in this slide, but I'm just showing again that policy and structural and governance complexity in which the person on the floor finally finds themselves. So having seen all of this complexity, and I noticed Lynn Cowan on the news last night, who's the ED of SA Health, speaking to an inquiry on workforce and healthcare plans, said that it wouldn't be months, but it'll be years before we could get real workforce change and address the complexity of these problems. So we really do need to think strategically, but act tactically. So just a little bit more about the context. In my research, it became obvious that to fully understand and try and address issues, we need to look at the context. And the health system does have 3 broad levels. So the macro level is that federal level, and that has political and economic responsibility for health and related sectors, including aged care and the primary healthcare sectors primarily. However, the meso, or state and territory level, also has political and economic responsibility for the hospital systems. However, there is a deficit of reporting requirements between the federal framework and state healthcare plans, specifically addressing transitional services or continuity of care. So therefore, it becomes evident at a micro level where we are with our organisations and workplaces These are state-funded and politically controlled, yet we consistently intersect with aged care and primary health care systems, which are federally controlled. So at our front and back doors, what results is bed blocks, ramping, and no systematic transitional care assessment or management into and out of that acute secondary health care system. Continuity of care is not prioritised. Instead, an immediate bed fix, which is in the form of discharge planning and crisis management, is addressed, rather than transitional care planning. So it becomes a fragmented, disorganised at best, or missed or neglected care at worst results. So there's a real malalignment of overall health service organisation and delivery, which I fear is not news to you. However, solutions, what can we do? Some things, I think, if the issues are present at the macro to micro level, I think solutions need to be at that place as well. And so we need to be realistic about what we can and can't address from our own point of view.
You have 1 minute.
1 minute, thank you. So the key issues are that there needs to be engagement across all of those three levels. But to focus down on what we can do at a micro level, there needs to be consultative engagement, which does have to happen between the macro and meso levels. At the micro level, GPs require ongoing access to specialist healthcare. There needs to be a fundamental shift from discharge planning to transitional care planning. Nurses need to incorporate a brief risk assessment of readmission to hospital and transitional care coordination. Roles and services need to intersect between hospital and primary healthcare sectors. Primary healthcare network and local healthcare network funding is needed to enable nursing services and role reform. And of course, none of this is possible without leadership, culture change, and coordinated multidisciplinary research and transitional services. So our job is to present the evidence-based solutions. We need to be cognizant of the context. A key part of the strategy and tactics is to consult and collaborate. And we need to identify which part of the system we are in, whether it be macro, meso, or miso, and really, or micro rather, and really put into operation tactics that will address that, because we need certain futures, certain solutions for an uncertain future. Thank you very much for your patience and presence.